Hi, I'm Dr. Abdol, an emergency medicine specialist, and I'm eager to share a compelling case that recently unfolded in our emergency room. Imagine a scenario in which an 82-year-old man presents to the emergency room with severe dyspnea. His face is lined with distress, his breaths come in ragged gasps, initial vital signs are concerning. His heart is racing at a clip of 120 beats per minute, the respiratory rate is alarmingly high at 45 breaths per minute, and oxygen saturation is low at 87%. His legs are swollen with bilateral edema, and his lungs sound like a crackling fire wheezing with every breath. To top it all off, his blood pressure is soaring at 165, a clear indication that his body is under extreme stress. The severity of his condition is evident, and it's clear that immediate intervention is required. Recognizing the urgency of the patient's condition, you initiate immediate intervention. In response to the patient's critical state, you initiate oxygen therapy and establish a quick IV line. This is an 82-year-old man in distress, his heart racing at a rate of 120, struggling to breathe with a respiratory rate of 45, and with an oxygen saturation dropping to 87. His blood pressure is elevated at 165 and his legs are swollen with edema. On auscultation, crackles and wheezes fill his lungs, a distressing symphony of sounds that point to severe respiratory issues. Without wasting a moment, you begin oxygen therapy with a high-flow mask set to deliver 8 liters per minute. You set up an intravenous line, a critical lifeline to administer necessary medications and fluids. With the oxygen support and IV line in place, you swiftly move on to the bedside ultrasound. Every second is crucial here. The ultrasound probe glides over the chest, revealing in real time the condition of the heart and lungs. The ejection fraction is reduced, a sign that the heart isn't pumping as efficiently as it should be. On the screen you spot the bilateral B-line artifacts, a sonographic pattern often associated with pulmonary edema. As you move the probe to the right side of the chest, you spot a pleural effusion. This is an abnormal collection of fluid in the pleural space, the cavity between the lung and the chest wall. It's another piece of the puzzle, another indicator pointing towards pulmonary edema. The ultrasound paints a clear picture within a minute. Reduced ejection fraction, bilateral B-line artifacts, right side pleural effusion. All these findings suggest pulmonary edema. It's a condition where fluid fills up the air sacs in the lungs, making it difficult to breathe. Given the patient's history of chronic obstructive pulmonary disease, or COPD, and congestive heart failure, or CHF, a viral infection leading to decompensation is suspected. This could be the trigger that has tipped the scales, causing a severe exacerbation of his chronic conditions. The initial assessment and bedside ultrasound have not only helped to identify the problem, but also set the course for immediate treatment and intervention. Based on the ultrasound findings and the patient's history, you consider a mixed presentation of chronic obstructive pulmonary disease exacerbation and CHF decompensation. This is a challenging diagnosis, as the symptoms overlap and can be confusing. However, the ultrasound's revelation of reduced ejection fraction, bilateral B-line, and right-side pleural effusion shed light on the underlying issues. The patient's history of COPD and CHF, coupled with the severe dyspnea and elevated blood pressure, paint a vivid picture. This is a patient in distress, and a clear, swift treatment plan is necessary. So what are the next steps? You initiate treatment, targeting the most likely culprits. You begin with nebulized Ventolin and Atrovent. These medications help to open up the airways, providing some relief from the patient's respiratory distress. They are used widely in treating chronic obstructive pulmonary disease and have the potential to make a significant impact in this case. Next, you administer 40 milligrams of Lasix and was repeated once again. This diuretic works to reduce fluid buildup, which is important given the signs of pulmonary edema and the patient's CHF history. The aim here is to alleviate the strain on the heart and lungs, helping to improve the patient's breathing and overall condition. Alongside these treatments, you start intravenous nitroglycerin at 10 micrograms per minute. This vasodilator aids in decreasing the workload on the heart, easing the symptoms of CHF, and potentially improving the ejection fraction. As healthcare professionals, we know that treatment is not a one-size-fits-all approach. It's about understanding the patient's unique presentation and tailoring the treatment to their needs. It's about continuously assessing and reassessing, making adjustments as necessary. In this case, despite initiating treatment, the patient's condition doesn't significantly improve, and respiratory distress persists. This is a stark reminder that in medicine, we often have to pivot and adapt, always keeping the patient's well-being at the forefront of our decisions. In light of the patient's persistent distress, you decide to insert a Foley catheter while maintaining close monitoring. This decision is crucial to ensure that every aspect of the patient's condition is being addressed. While the patient's respiratory distress continues, you are dedicated to providing the most comprehensive care possible. During this phase, the critical nature of continuous monitoring cannot be overstated. Each passing moment provides valuable information that can be used to fine-tune the treatment approach. The patient's condition doesn't significantly improve and respiratory distress persists, but you remain vigilant, adjusting treatments as necessary. Recognizing the need for more aggressive intervention, you decide to transition to NIV, BiPAP, bilevel positive airway pressure therapy. This decision is guided by the persisting severity of the patient's respiratory distress and the need to provide more substantial respiratory support. In determining the settings for the BiPAP, you opt for an expiratory positive airway pressure, or EPAP, of 5 and an inspiratory positive airway pressure, or IPAP, of 13. The fraction of inspired oxygen, or FiO2, is set at 100%. These settings are chosen carefully, taking into account the patient's current state and the goal of maximizing oxygen delivery while minimizing the potential for further lung damage. The Foley catheter is inserted smoothly, ensuring the patient's comfort throughout the procedure. All the while, you keep a close eye on the patient's vitals and response to the ongoing interventions. Then, the turning point arrives. Within minutes of initiating the NIV, BiPAP, the patient shows marked improvement. It's a testament to the power of swift, targeted intervention and the importance of continuous, diligent monitoring in acute care settings. The patient's relief is palpable as the severe respiratory distress begins to subside, but the journey is far from over. Continued monitoring and care will be necessary to ensure the patient's full recovery. And with that, we see the power of medical expertise and continuous monitoring in action. Within minutes of initiating IV BiPAP, the patient shows marked improvement. Despite the initial improvement, you decide to admit the patient to the ICU for further observation. It's a decision not taken lightly, but in the best interest of the patient, considering the severity and complexity of his condition. Post-stabilization, you conduct further diagnostic tests and the results are concerning. Troponin, a protein released when the heart muscle has been damaged, is found in elevated levels. This is a strong indicator of a heart attack or hypoxia. Similarly, the patient's BMP or basic metabolic panel is also elevated, suggesting possible acute on chronic heart failure. And then there's the dimer levels. They're abnormal, which could suggest a blood clot. This trio of findings paints a picture of a patient in need of immediate and intensive care. So what's next? You initiate a regimen of heparin and Interpol. Heparin is an anticoagulant, a blood thinner, and it's administered to treatment or prevent new clots from forming while allowing the body to naturally break down any that already exist. Interpol, on the other hand, is used to treat or prevent heart attacks. The ICU is a place of constant vigilance. Every change is noted, every aberration addressed. It's a place of proactive care, where the goal is not just to treat, but to anticipate. And in this case, you're staying ahead of the curve. As the patient stabilizes, you reflect on the steps that brought you here. From the initial assessment to the bedside ultrasound, from the differential diagnosis to the treatment initiation, and finally, the decision to admit to ICU. Every step was crucial, every decision vital. In conclusion, a multidisciplinary approach incorporating bedside ultrasound, differential diagnosis, and continuous monitoring was crucial to providing optimal patient care. It's a testament to the power of collaboration between emergency medicine, cardiology, and other specialists. And ultimately, it's a testament to the power of medicine when practiced with diligence, dedication, and a deep understanding of the human body and its many complexities.